Welcome. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of the screen. We'll have time for the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay. So just want to note that today's session is going to look a little different. Dr. Stathatos is going to give a very brief, informal talk about the thyroid gland. We're going to open up the chat earlier today, so if you have any questions, feel free to enter them in the chat. So joining us today, we have the pleasure of having Dr. Nikolaos Stathatos. Dr. Stathatos is a doctor for the thyroid unit at Mass General Hospital. He is also an assistant professor in medicine at Harvard Medical School. In recognition of Thyroid Awareness Month, he joins us today to give a talk on the thyroid gland. So please join us in welcoming him.
Thank you. So my name is Nikolaos Stathatos. I'm one of the endocrinologists in the thyroid unit here at MGH. And today we are going to be talking about the thyroid gland. I'm just going to spend a few minutes, maybe 5 minutes, going some basic things about what the thyroid gland is and what it does. And some of you will already know this information. Some of you will, it'll be new for someone. For some of you, just bear with me for a few minutes, and then please feel free to add your questions so that we can cover any topics you may want to talk about the thyroid gland. So the thyroid gland is an organ that is located here at the base of the neck, and it is in the shape of a butterfly. Its name actually comes from the Greek word shield, ancient Greek word of shield, not butterfly, but it looks like a butterfly. I can actually show it to you here. This is what a normal thyroid gland looks like. And it sits right here at the base of the neck, and it wraps right around the windpipe. This is the windpipe. This is our voice box. The pointy thing here is Adam's apple. The thyroid gland sits right below the voice box and wraps around the windpipe. And it's located basically here, right at the base of the neck, under the skin. Now, the function of the gland, the thyroid gland makes thyroid hormone, which is a substance. Literally everything in our body needs thyroid hormone to work. From our hair on our head to our toenails in our feet, everything needs thyroid hormone to function properly. And it has to make sure that it makes enough thyroid hormone to cover what the body needs. Now, there are two types of thyroid hormone in the human body, two more active, I would say, types of thyroid hormone. One is called T4 or levothyroxine, and the other one is called T3 or liothyronine. The difference between the two is the following. The thyroid gland mostly makes T4, which is the levothyroxine. And T4 is kind of what we call a prohormone. It's what the thyroid gland mostly makes, but it's not the actual active hormone that the body uses. T3 is the actual active hormone that the body uses. And the way this works is that the thyroid gland makes the T4, this hormone, and this hormone goes to the body, and the liver, with the muscles doing much of the work, convert the T4 to the T3. Think of it as something like this. Think of T4 as the crude oil that comes out of the oil well, but your car cannot use crude oil, it needs gas, and gas is the T3, and the liver and the muscles are the refineries converting T4 to T3. Now, where it gets more complicated is that every part of the body uses T4 and T3 differently. And I'll give you the two extreme examples. The heart will use any T3 that is in the circulation, will work on the heart. Whether if it's a lot of T3, it will cause fast heart rates and palpitations. If it's not enough, it will cause slow heart rates. Most of the brain most of the brain actually ignores the T3, the active hormone that the muscles and the liver make, takes the T4 and it converts it to T3. So we can give somebody all the T3 in the world, most of the brain will completely ignore it. So how the body regulates those two hormones is very complicated. Finally, the thyroid gland is regulated is controlled, I would say, by the pituitary gland, which is a brain, which is an endocrine gland, a hormone gland in the brain right behind the eyes in the middle. And it does it by making a hormone called TSH, thyroid stimulating hormone. And this hormone goes to the thyroid gland and tells it to make more or less thyroid hormone depending on what the body needs. This is a basic overview of how the thyroid gland works. And now, unless anybody has any questions about that, I'm just going to briefly go over a couple of things of what are the common problems that we face with the thyroid gland. So I'm going to pause here for just a second to see if anybody has any questions about the thyroid gland itself, how it works and what it's supposed to do. Okay, I got a question that is very broad. It states, is hypothyroidism inherited? Hypothyroidism means low thyroid, that the thyroid gland is not making enough thyroid hormone. Is it inherited? The most common cause of hypothyroidism is what we call an autoimmune problem, Hashimoto's thyroiditis, and any autoimmune problem can potentially be inherited. There's two factors for any autoimmune problem: genetics, which we inherit from our parents, and an environmental factor that triggers the autoimmune response because of our genetics, because of the genes that we inherited from our parents. So the answer to your question is there's some degree that of familial issues, meaning the genes we inherited from our parents, but it's not the only reason why we develop low thyroid. Let's talk a little bit about the other part of the question, just to get it out of the way, is what are the signs of thyroid cancer? We're jumping a little bit here, but the thyroid cancer usually doesn't have any symptoms. It presents itself either incidentally, somebody looked in the neck and found something, looked in the neck for other reasons, the carotid arteries, the cervical spine, got imaging, and there's a thyroid nodule, or the doctor felt a nodule, but it usually doesn't have any symptoms per se. It has to be very, very advanced to give symptoms such as pain or difficulty swallowing or breathing, but that's very rare, and in very rare cases of very advanced thyroid cancer, fortunately. There's another question that says, does aging in itself affect the thyroid? Aging affects all the body, everything in the human body, including the thyroid gland. The function of the thyroid gland does change with age. To give you an example, we are in the process of potentially creating age-specific normal values for the thyroid test. We don't have them yet, but there are a lot of studies undergoing right now to determine what are the proper normal values, because they seem to be different for somebody who's 30 versus somebody who's 80 years old. So the answer is yes to that, as far as function is concerned. And also, the older we get, the more likely it is that we're going to develop nodules, lumps or bumps in the thyroid gland. So that's another way that the age affects our thyroid. Let's now briefly talk about the problems that we face with the thyroid. We touched on hypothyroidism, which is low thyroid, meaning the thyroid gland is not making enough thyroid hormone to cover what the body needs. The most common reason is what we call primary thyroid failure, like the thyroid gland does not produce enough hormone by itself because there's inflammation, as I said, most commonly because of an autoimmune problem. And let me explain what that means. Autoimmune problem means that the immune system, by mistake, is attacking the thyroid gland, and it is making it work less and less and less. Now, it's not black and white, either the thyroid gland works well or it doesn't work at all. Over a period of usually years, it starts working less and less and less, to the point that at some point we have to intervene because it's not making enough to cover what the body needs. Alternatively, it can be a problem with the pituitary gland that I told you, the gland in the brain that controls the thyroid gland, that is not making enough of the hormone, the TSH, to stimulate the thyroid gland, but that's very, very rare. So the other side of this coin, the opposite side here, is hyperthyroidism, which is an overactive thyroid gland, and it means that the thyroid gland is making more thyroid hormone than the body needs. In that case, what happens is that Again, it's most commonly an autoimmune problem, meaning that the immune system by mistake is forcing the thyroid gland to work harder than it's supposed to work. And it makes it by creating antibodies that are supposed to fight off infection. Only in this case, these antibodies, instead of fighting off infection, they attack the thyroid gland, and that they're forcing the thyroid gland to work harder. These same antibodies can also attack the eyes, the tissues around the, not the eye itself, but the tissues usually around the eyes. And these antibodies can cause a lot of inflammation and swelling, and then sometimes make the eyes even protrude out. And that's why the eyes sometimes, not always, occasionally can become swollen and inflamed in cases of hyperthyroidism of an overactive thyroid gland. Most cases of hyperthyroidism of an overactive thyroid gland don't have the eye problem, but occasionally we do see it. So other reasons why the thyroid gland may be overactive is because the thyroid gland has a nodule, a lump, that has lost control, and is this lump alone, not the whole thyroid gland, is pumping out more thyroid hormone than the body needs, and the result is the same, an overactive thyroid gland. More thyroid hormone in the blood than the body basically needs. Those are the two main ways that the thyroid gland can be overactive. Finally, there's a third way where the thyroid gland is being destroyed by some kind of inflammatory process, some kind of inflammation, and the thyroid hormone that is stored in the thyroid gland leaks out, because the thyroid gland stores a lot of thyroid hormone normally, just in case it needs it to release it in the future. And if there's inflammation, these stores are being broken up, and whatever is stored in the thyroid gland leaks out, and then as a result, there's too much thyroid hormone in the blood. So let's talk now a little bit about the symptoms, how these problems present. In case of hypothyroidism, the common symptoms of low thyroid, hypothyroidism, would be low energy, constipation, dry skin. For a young woman in her reproductive years, her cycles will become more frequent and heavier, hair loss potentially, sleeping more than usual. Those are the symptoms of low thyroid. There's a misconception that patients with hypothyroidism can gain large amounts of weight, 50 pounds or 100 pounds. That's actually not true. Patients with hypothyroidism may gain some weight, 5-10 pounds, because this gel-like substance forms everywhere in the body and accumulates everywhere in the body. It's what we call mixed edema. But that's not actually fat tissue. It's a substance that collects because when somebody's hypothyroid, but it always goes away when hypothyroidism is treated. So on the opposite way, in cases of hyperthyroidism, the symptoms are basically the opposite. Patients feel very jittery, very shaky, like they're irritable sometimes. Their hands shake. They may have palpitations. They may be sleeping less. For a young woman, her cycles may become lighter and less frequent. Weight loss, in contrast, patients with hyperthyroidism can lose a lot of weight, and which they regain once we treat the problem. Now, there's another question that says, what happens if the thyroid blood test is marginally out of range, no treatment, and is there anything that we can do to bring it normal, to bring it back down to normal? The answer is usually no. There's not much we can do. Please keep in mind that very often, most like over 50% of borderline abnormal thyroid blood tests usually come back to normal by themselves without any intervention, without any treatment or anything like that. But is there any? The question is also, it says, are there any foods that we can eat or avoid in order to bring it into the normal range? The answer is no. There's no studies, there's no evidence to suggest that any kind of diet will actually help or help in bring the thyroid hormone levels to the normal range or not, or make it worse. So diet doesn't seem to play a significant role that we know of. I know there's a lot of things out there over the internet about this diet doing this and this diet doing that, but as far as I know, there's no good evidence about any particular diet being helpful or harmful to the thyroid gland. With some extreme exceptions, the rule, what I tell my patients is this: just eat healthy, avoid extremes. Don't eat too much of anything, and don't avoid anything either. You know, for the thyroid gland, just a good, healthy, nutritional diet is more than enough. You don't have to avoid anything or take anything in excess. Any other questions so far about hypo or hyperthyroidism? Okay, until other questions come up, I'm going to go on and talk about the next very common problem that we see in thyroid, and that's thyroid nodules, little lumps inside the thyroid gland. If you look at a normal thyroid gland, it's usually an organ that is very uniform. It doesn't have any lumps or bumps, and it's very uniform. A thyroid nodule would be something like this. I don't know if you guys can see clearly on my camera, but you can see this little lump right there. This is what a thyroid nodule will present like. And sometimes people can have one of these. Sometimes people can have many of these on both sides. So how do these lumps form? Let's take a step back. If you look at a normal thyroid gland, if you look at it under the microscope, imagine little microscopic little balloons, little cysts stuck to each other. That's what the thyroid gland is made out of. These little cysts that are microscopic, that you cannot see them on the naked eye, and that's what the thyroid gland is made out of. When a lump, like I showed you, forms, it can form in three ways. One of the little balloons fills up with a lot more fluid that we can actually see with an ultrasound or a CAT scan. So that's what we call a thyroid cyst. The cells that make up the wall of the cyst can start to multiply to form solid masses made out of tissue, not fluid, or it can be a combination of the two. It can be partly fluid, partly solid mass. So these things are very common, and the older we get, the more likely it is that we're going to find them. This applies particularly for women. There was one study that I thought was a little bit on the extreme side that suggested that the chance that we're going to find a thyroid nodule in a woman, but if we do an ultrasound on her, is about the same as her age. But I think that statistic is a little bit extreme. The point being that it is very common, and particularly the older we get, the more likely it is for somebody to have thyroid nodules, particularly for women. Now, the vast majority of these nodules are not cancerous. They're not malignant. They're not cancer, and they don't cause any problems. Because that's the main concern that we have when somebody has a thyroid nodule. Could this nodule represent a cancer? Now, the first thing we do when somebody has a thyroid nodule is we look for the blood test. We want to make sure that the thyroid function is normal, just to make sure that this nodule is not hot. It's not making more thyroid hormone than the body needs. In the absolute vast majority of cases, thyroid functions are normal when somebody has nodules, and we don't have to worry about the function of the thyroid gland. We just have to address the nodule. So then we look at the nodule itself. What are the odds? How worried are we that this lump could potentially be a cancerous nodule? Let's take one at a time. If it is a pure cyst, if it's just made out of fluid, the risk of cancer is almost negligible. We don't have to biopsy. We don't have to do anything for it. We just follow these and just watch them. Rarely these things can be really big, and we're not worried about cancer, but we're just worried about the size, and it may be very visible or it may be very uncomfortable for the patient. And in that case, we can take the we can take the fluid out. When the thyroid nodule is solid, then that's when we have to decide whether we have to do a biopsy or not to decide whether it is benign or cancerous. The way it looks on the ultrasound, which is the most sensitive test that we have, is the best way to know whether we need to worry about this nodule or not. Some nodules do require biopsy, some nodules don't. And usually, if we are worried, or if we are worried, or if we are not certain about a nodule, then we will do a biopsy. There's a question about, again, food and thyroid function, and I will tell you again the same thing. I am not aware of any particular diet that I would recommend for any kind of thyroid problem. I don't know that there's any food that we need to avoid or any food that we need to eat in excess in order to try to maintain good thyroid health. There are certain rare situations that we ask patients to follow one diet or the other. For example, a simple example is if somebody is to be treated for thyroid cancer, we may sometimes ask them to follow what we call a low iodine diet, a diet that is low in iodine. But usually, other than that, we recommend just a good, healthy, balanced diet without any specific focus to the thyroid gland. I do not know of any specific diet that has any good or bad effects on the thyroid gland, as long as it's a balanced diet. Again, I did not recommend any diet at all. I said that a good, healthy diet is the best option. There is no one diet that I would recommend for the thyroid gland. I usually recommend my patients just follow a good, healthy, balanced diet and that's it. I don't know of any diet that is going to be good or bad for the thyroid gland. Just a good, healthy diet, which is good for everything, not just the thyroid gland. Any other questions so far? Are there thyroid transplants? No. There are nobody's ever done a thyroid transplant. That's an interesting question, and a few patients have asked me that. But given how easy it is, or simple, I would say, it is to replace thyroid function, to replace what the thyroid gland does if somebody loses a thyroid gland, nobody has ever attempted anything like a thyroid transplant. I absolutely agree with you. There are some patients that take thyroid hormone and they never feel well, even though their numbers are quote unquote in the normal range. And we try all sorts of combinations of T4 and T3, or this formulation of thyroid hormone or that formulation of thyroid hormone. They still don't feel well, and we don't know why. And the problem is that transplants are very complicated, and they have a lot of side effects because patients have to take a lot of very nasty medications to maintain a transplant, medications that are very toxic, that it is not worth to even consider a transplant for the thyroid gland. Did you say what is prescribed hormones for hyper? Okay, for hypothyroidism, we prescribe the same hormone the thyroid gland makes, the levothyroxine, which is the main product of the thyroid gland itself. It's what the thyroid gland makes, and that's what we prescribe. It's called levothyroxine. There are many formulations of it, many different types of companies, brand names, and gel capsules, tablets, things like that, liquid, but it's mainly levothyroxine. For hyperthyroidism, we don't prescribe hormones. We prescribe medicine that goes to the thyroid gland and blocks the thyroid gland from working more than it should be working. The most commonly used medication is called methimazole. Again, it is not a hormone. It's just a medicine that goes to the thyroid gland and slows it down because it's working more than it should. Does donating blood affect the thyroid? No, donating blood should not affect the thyroid function at all. No, because you're just going to, there will be some thyroid hormone in the blood you're going to donate, but it should not affect thyroid function at all. No, it should not. There was a question about whether donating blood affects the thyroid function, and the answer is no. I don't think donating blood will have any negative effect on the thyroid gland, no. Are there better treatments for the horizon for people? Are there better treatments on the horizon for people who have thyroid cancer with the BRAF mutations metastasized to the lung? Okay, very specific question. The question is, people who have thyroid cancer that has metastasized and carry what we call a BRAF mutation. Cancer cells, cancer tissue usually has changes in the DNA that make the cells, these cancer cells multiply more rapidly and form tumors, cancer tumors. And for the thyroid gland, one very common mutation, one such very common change is called BRAF. It's a change we often see in patients who have what we call papillary thyroid carcinomas. And the question is, are there better treatments for people who have lung metastases to the lungs, metastasis to the lungs? And the answer is yes. Nowadays, we're getting new medications almost monthly, and we're doing clinical trials all the time to try to figure out exactly what medicine works for who. But there are a lot of things coming down the pipeline for these thyroid cancers. And the answer is yes to that. Should a person with hypothyroidism see both a PCP and an endocrinologist? No, not necessarily. Most primary care doctors are able and willing to manage hypothyroidism. It's a relatively simple matter of putting the patient on thyroid hormone replacement, levothyroxine, making sure the blood test is normal, and making sure the patient feels well. I always tell my patients it's a combination of not just the blood test being normal, but making sure the patient feels well as well. And for the most part, for most cases, it's a relatively simple procedure. The primary care doctor will put the patient on thyroid hormone, and then just follow the blood test and make sure they're okay, and the patient usually feels fine. So an endocrinologist is not needed in most cases. In cases where there's trouble, the doctor and the patient cannot find a good regimen that works well, or the blood tests are not normal and they don't know why, then absolutely a referral to an endocrinologist is necessary. Is there more info on treating Hashimoto's? Are they treated separately? When you say separately, if you can clarify what do you mean separately from what Hashimoto's? Hashimoto's, the inflammation itself, from the Hashimoto's itself, the inflammation is not treated separately in any way. We don't have any specific treatment for the inflammation itself. There's nothing we can do to reverse it or make it go away or stop it. All we can do is replace the function of the thyroid gland because the thyroid gland is not working well. It's working less than it should be working. But we don't have any specific treatment for the Hashimoto's itself. How does the CT scan show nodules? No, thank you. The CAT scan is not the best study to look inside the thyroid gland for thyroid nodules. The best study to look for thyroid nodules is an ultrasound study of the neck, not a CAT scan of the neck. The ultrasound will give us great detail about what's going on inside the thyroid gland. It won't give us detail about what's going on outside the thyroid gland, around the thyroid gland. The CAT scan does the opposite. It gives us good detail about what's going on around the thyroid gland, but not what's going on inside the gland. So when we want to look for the nodules themselves, we want to have an ultrasound study, not a CAT scan. Does the increasing number of cysts in women increase the risk of cancer? No, it does not. The fact that the nodules go up as we age does not increase the risk of cancer. The risk of cancer is, in general, when somebody has nodules in the range of about 5 to 10%, whether they have 1 nodule or 10 nodules. It doesn't change that. Is thyroid cancer hereditary? The vast majority of thyroid cancers, I would say almost 95%, 97% of cancers don't seem to be hereditary. There are some rare cases of cancers. There's a thyroid cancer type called medullary thyroid cancer that can sometimes be hereditary. Very rarely, follicular thyroid cancer can also be hereditary, but the vast majority of them are not. Are there tests for family members to take to see if they're at risk? If a family member is diagnosed with a medullary thyroid cancer, specifically medullary thyroid cancer, that person has to have genetic testing to see if they carry one of the familial types. And if they are positive, if that person who already has the cancer is found positive, then the family member should be screened for the same mutation. Yes, absolutely. But for most thyroid cancers, the answer is no, there's no test for the family members. Or if they have thyroid cancer since. And in general, we don't recommend screening. If someone, let's say a family member has one of the run-of-the-mill thyroid cancers, like the papillary, we don't recommend screening for the rest of the family. We recommend everybody goes to the doctor, they have the neck palpated, and if the doctor feels a lump, then they should follow up with that, but there's no specific recommendations for screening unless the patient falls into that very small group of people. With full thyroid removal, does synthetic levothyroxine function the same way as the natural one, as you expected? Tuning into, yes. The levothyroxine that we provide when somebody has no thyroid gland left is chemically identical to the levothyroxine the thyroid gland is making. So for the vast majority of people, once it's in the blood, once it gets absorbed and gets into the circulation, the body doesn't know where it's coming from. It's coming from the thyroid or from a tablet. So it's handled the exact same way as the natural the T4 the thyroid gland makes, and it converts it to T3. So it should not make any difference. Is there any routine blood work that indicates how well or not the thyroid? The question is there any blood test to tell us how the thyroid gland is functioning? The most sensitive test that we have to test for the function of the thyroid gland is the test called TSH, thyroid stimulating hormone. That's the hormone the brain makes, the pituitary gland that we talked about makes, that regulates the thyroid gland. All our studies have shown that it is by far the most sensitive test that we have, but please be careful because it works the opposite way. When the TSH is high, it means the thyroid hormone is low. And when the TSH is low, it means thyroid hormone is high. So it works the opposite way. High means low and low means high. So please don't get confused with that. Do you excise cysts? In general, no, we do not remove cysts unless they get really, really big. And what we try to do is we try to drain them at least once. The problem with draining a cyst is that it has at least a 50% chance that it will come back if it's a pure cyst, no solid part of it, okay? If it's a pure cyst, if you drain it, you can make it a lot smaller, but there's at least a 50% chance that the fluid will come right back within a few weeks or a month. And depending on how big it is, if it's really, really big, then in that case, we can consider taking it out. Nowadays, we have other options. We can potentially take the fluid out and inject a little bit of alcohol in the cyst, and that alcohol will hopefully, burn the cells that make all the fluid in the cyst, and it will not allow them to reaccumulate the fluid. But very, very occasionally, I would say very rarely, we have to excise cysts. In most cases, no, only because they're not that big. When it's really big, yes, we can potentially remove them. Please feel free to further comment if one of my answers was not clear, okay? Can you wean yourself off levothyroxine medicine after the levels are normal? Usually the answer is no. When somebody has low thyroid, let's say for Hashimoto's, it is a permanent condition, and these people need to take levothyroxine for life. It's not something that you can wean off. Okay, very rarely, there are some cases, like I said, when there's inflammation that destroys the thyroid gland, and the thyroid hormone the thyroid gland can produce is exhausted, and these people can have a low thyroid, hypothyroidism, but then the thyroid gland can recover by itself. So we give thyroid hormone for a short amount of time, and those people can actually stop thyroid hormone. But for the vast majority of people who have the run-of-the-mill low thyroid, then the answer is no. You cannot wean off. You cannot wean off the thyroid hormone, unfortunately. What kind of thyroid cancer metastasizes to the femur? The answer to that is any thyroid cancer can metastasize to the femur. Most commonly, it's cancers like the follicular thyroid cancer that metastasizes, which is it's about maybe 5 or 10% of all thyroid cancers. Papillary can metastasize, but it's highly unusual. And medullary, which is 1 or 2% of all thyroid cancers, can also metastasize to the femur. But the most common, I would say, would be probably a follicular type of thyroid cancer. Why is somebody with hyperthyroidism at high risk of atrial fibrillation after the age of 64, especially if no family history of heart disease? Okay, atrial fibrillation is an irregular heartbeat that can predispose patients to blood clots and potentially strokes. So it's a dangerous arrhythmia. It's a dangerous heartbeat, irregular heartbeat. And when somebody has an overactive thyroid gland, they are at risk of developing this atrial fibrillation. And the question is, why is somebody at more risk when they're over the age of 64 or 65? Anybody, the older we get, the less our heart usually doesn't work as well as when we are young. There's more fibrosis. There's more damage. The heart is more. To put it in simple terms, the heart is more tired. So any insult is more likely to cause trouble. People who are older, over 65, they're at increased risk of developing atrial fibrillation, even at very mild forms of overactive thyroid gland, very mild cases. For somebody who is in their 30s or 40s would not develop atrial fibrillation with very mild hyperthyroidism. Somebody who's 65, 70, or 80 years old is more likely to develop it. So it's more dangerous for the older age group. But I don't think, that's why, even if there's no family history, that's why these patients are more sensitive, because the heart is the blood flow of the heart is not as good. There's more atherosclerosis, not getting enough heart, and the excess thyroid hormone is just enough excess trigger to make somebody more susceptible to the atrial fibrillation. I hope that explains that. Is it common to have a thyroid nodule to cause cough? Common? No. It's actually rare, because the nodule will have to be really big to press on the windpipe. It's not impossible, but it's not common at all. So you would have to have a really big mass pressing on the windpipe to do that, and it's not common. I would say it's unusual. Do thyroid issues affect heart function or brain functions apart from cancer? As I said, thyroid function affects everything from our hair on our head to our toenails in our feet. It can affect the heart, the brain, the kidneys, the liver. It can affect everything. Just like we talked about with the previous question, if somebody has too much thyroid hormone, they can develop this irregular heartbeat and arrhythmia, this atrial fibrillation, which can be really, really dangerous sometimes, and it can cause stroke. Can it affect the brain function? Yes, people who have an overactive thyroid gland, the same situation, they can become agitated and the mental status changes and they're irritable. Or if they have low thyroid, they can slow down and develop depression and not feel well. So it can affect everything. So the brain and the heart are definitely included in that. Any other questions? Anybody else want to talk about anything? Now, the last comment that I will make is that please be aware that several medications can affect the function of the thyroid gland. A very common and well-known example is a heart medication called amiodarone. It's a great medication. It really has saved countless lives, but it can have a lot of side effects on the thyroid gland. It can make somebody hypothyroid, it can make them hyperthyroid, depending on what the status of how the thyroid gland functions. So that's a medication that your doctor needs to know and test you for your thyroid gland. Many new cancer medications can have a lot of side effects with the thyroid gland, so that's always something that you always need to remember, okay? Is feeling cold in hands and feet an effect of hypothyroidism? Yes, if somebody's hypothyroid, they have what we call cold intolerance. They do not tolerate cold very well. They feel colder easier, so they can have cold hands and feet. Now, please be careful here. Having cold hands and feet, it can be due to a number of different reasons. Somebody can be anemic, somebody can simply be built that way, and they're more sensitive to cold, and it has nothing to do with the thyroid gland. But if somebody has low thyroid, they have hypothyroidism, they can most certainly have cold intolerance and feel cold hands and cold feet and cold everywhere, not just the hands and the feet. So the answer is yes. But having cold hands and feet does not necessarily mean you have low thyroid. It means it needs to be looked for, and it could be the low thyroid, but in many cases it is not. I don't see any other questions coming in.
All right, so I think that's all that we have for today. Thank you so much for your time. Do you have any final thoughts you'd like to share with the audience?
There's another question, if you don't mind. Is natural thyroid medicine any better than synthetic? In general, the answer to that question is no. We don't think that first of all, let's talk about what the natural means. Natural thyroid hormone, natural thyroid medicine means most commonly they take thyroid glands from pigs and they crush them down into tablets, and that's what the natural thyroid medicine is made out of, pig thyroid tissue. The problem with that is there are many issues with that. Number one, the pig thyroid tissue has a lot more T3 than T4, so it's than the human thyroid. So patients usually get a lot more T3, which is usually not healthy, and the amount of hormone in each tablet is very difficult to regulate. So we in general we much prefer the synthetics versus the natural, the so-called natural ones. But sometimes patients do prefer the natural ones. But in general, we prefer much the synthetic, not the natural ones. Should replacement of thyroid hormone palliate all symptoms? Listen, the question is, if we fix the hypothyroidism, should all the symptoms of hypothyroidism go away? The answer is yes. All the symptoms should go away. Now, again, the problem here is this. Some of these symptoms, none of these symptoms are specific for the thyroid gland, meaning the same symptoms can be caused by many other problems. So what we usually say is this: if we find a thyroid problem and the patient has some symptoms, we treat the thyroid problem, bring the hormone levels into the normal range, and we wait for a while. Thyroid hormone takes a while to function. Okay, it doesn't work right away. So with normal numbers, we wait for a few months. If some symptoms remain, even though the numbers are normal, then the patient needs to look for other causes for those symptoms, not the thyroid, because it doesn't seem like those symptoms are any longer related to the thyroid. I hope that makes sense. Since thyroid affects everything in the body, can the diagnosis of it as a cause be missed more often? Yes, I'm pretty sure the diagnosis is missed often. Nowadays, any symptom, most every doctor will check a TSH and will know if the thyroid gland is working well, but it can certainly be missed. Yes, absolutely. If a patient with hypothyroidism enters remission, how will they be monitored in the future? Well, if they are in remission and they take no medications, then my recommendation is that they have a blood test every year, sooner if they develop new symptoms. If they develop the symptoms of hyperthyroidism that they know of, the shakiness, the tremors, the palpitations, then they need blood tests more frequently. But as long as they remain functional and they don't have any symptoms, once a year should be more than enough.
Are there any online resources that you recommend for patients who
Yeah.
are interested in learning more about this
Yeah.
topic?
Yes, there are two websites. Actually, one website. It's the thyroid, the American Thyroid Association website. It's thyroid.org, and it has sections for both physicians and patients. And for the section for the patients is very detailed for all thyroid problems. There's another question about Graves' antibody testing. Well, like as I said, Graves' disease is an autoimmune problem. The immune system makes antibodies against the thyroid gland that attack the thyroid gland and force it to work harder than it's supposed to work. We can actually test for those antibodies. There are two available tests for those antibodies, and we usually test for both. And the problem with these antibodies is the following: if the test is positive, if somebody has these antibodies, then we know they have Graves' disease. Unfortunately, there are cases where the patient doesn't have the antibodies and still have Graves' disease. So the presence of the antibodies makes the diagnosis, but the absence of the antibodies cannot exclude the diagnosis. So that's when we go to other testing, like a thyroid scan and uptake, to make the diagnosis. Does that answer the question? These antibodies, okay.
Why don't we give it a few more seconds to see if anyone else has any questions? Again, feel free to enter them in the chat.
Is there any way to lower the antibodies? Yes, in theory, for Graves' disease specifically, there is a study that has shown that if somebody takes selenium, a supplement, an elemental supplement, it may lower the antibodies for Graves' disease. But we got to be very careful here, because lowering the antibodies does not necessarily mean that the problem is going to go away. The titers, how high or low are the antibodies, does not always tell us how active the disease is. And lowering the antibodies does not always improve the actual clinical problem of an overactive thyroid gland. And in the one study that it showed to be beneficial, it showed that if particularly women take it for more than 6 months, they may be at increased risk of developing diabetes. So you got to be careful with these supplements, okay? They may have some benefits, but they certainly carry risk with them. So selenium may help lower these antibodies. Whether they're actually helpful or not is questionable, and they carry risk, so be careful with that.
So while we wait to see if there are any other questions, I did want to note that today's session is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center.
Any connections of estrogen and thyrogen and thyroid? In general, the answer would probably be no. Certainly, the thyroid gland has effects. If the thyroid gland is not working well, then the ovaries are not working well, and if the ovaries are not working well, it certainly can affect the thyroid. But in general, there's no direct link, like the direct link that we can say, oh, this estrogen problem is caused by thyroid, or this thyroid problem is caused by estrogen. The answer is usually no. There are some connections, but nothing concrete, nothing specific, nothing significant, I would say. Should I write the website for the information?
Sure, that would be great. Thank you so much. I think we do have a question in the chat.
I'm sorry. Oh, do you see an increase of cancer in recent years in young women 18 years, and why this may be? Okay, very good question. The answer is yes and no, and let me explain what I mean by that. In the past 10 to 20 years, there was this massive trend to start looking at thyroid glands in much more detail. Everybody was getting ultrasounds, everybody was getting thyroid biopsies, everybody was getting a lot more tests. And the result was that we were finding a lot more nodules, and among those nodules, we tended to find a lot more cancers. And most thyroid, this is something that is more helpful in women, obviously, than in men. But why it's the answer is, that's the yes part of the answer. The no part of the answer is this. It turns out that the majority of thyroid cancers that exist in humans are actually what we call clinically insignificant. They're cancers that are small cancers that form and never develop into anything bad. They can just sit there for decades, somebody's whole life, and never cause any problems. So yes, there was an increased risk of diagnosing thyroid cancer, but we were diagnosing thyroid cancers that are clinically insignificant, that never cause any problems. What most people don't know is that every human body actually develops cancer, except that over 90% of those cancers, our body can fight off, and they could never cause any problems. So diagnosing these cancers will only cause problems. It will lead to unnecessary surgeries. It will lead to unnecessary treatments. So was there an increased incidence of thyroid cancer? Yes, but it was an incidence of cancers that we should not have diagnosed. It was more dangerous to diagnose them than to leave them undiagnosed. So that's the answer. It's not like there was, more young women were dying from thyroid cancer. No, more young women were losing their thyroid gland unnecessarily because of thyroid cancer, but they were not dying from it, or they were not getting sick from it at all. The same applies, I think, for many breast cancers and prostate cancer for men. There are many cancers that should not be diagnosed because we cause more harm by treating them than leaving them in place.
Okay, so why don't we give it another few seconds to see if we have any final questions. So I think that's all the questions that we have for today. Many thanks in the chat, and thank you so much, Dr. Stathatos, for taking the time to give us all this helpful information, answer any questions people have.
My pleasure. My pleasure. Thank you.
All right, well, thank you so much, everyone. Hopefully you found today's session helpful. As I'd mentioned, the recording is available on the Blum Center website. We provided the web address and information to a website to learn more about the thyroid in the chat, so feel free to visit those sites.
Sorry, there was one comment that was a little funny.
All right, well, thank you so much, everyone. Have a
Thank
good
you.
rest of the day.
Thank you.